Good day, and welcome to the CAP webinar entitled The Proposed 2025 Medicare Policy and Payment Changes for Pathologists. My name is Pamela Wright. I am the Senior Director of Economic and Regulatory Affairs at the College of American Pathologists. During the next hour, we'll discuss the proposed regulations and policies for the Medicare Physician Fee Schedule and Quality Payment Program that will be used to reimburse pathologist services in 2025. And before I get started, I'd like to review a couple of technical details about today's presentation and also introduce our presenters. First, please type in your questions anytime during the presentation. There'll be time at the end of the presentation for our panelists to address them. We will select questions that are a representative sample of those submitted during our limited time here today. In addition, an archived recording of this webinar will be available later next week. The CAP will have a link to this presentation along with a PDF of the slide deck in the webinar section of the cap.org website. Let me now take a moment to introduce our presenters. Next slide. Our first presenter is Dr. Joe Saad, Chair of the CAP's Council on Government and Professional Affairs, also Chief of Pathology at the Methodist Hospital Systems in Dallas, and Adjunct Associate Professor of Pathology at the University of Texas Southwestern Medical Center. Next slide. Our second presenter is Dr. Ronald McLawhon, who is the Chair of the CAP's Economic Affairs Committee and a member of the CAP's Council on Government and Professional Affairs. Dr. McLawhon is also Professor and Vice Chair of Pathology and Director of Clinical Laboratories at University of California, San Diego. Next slide. And our final presenter is Dr. Gregary Bocsi. Dr. Bocsi is the Chair of the CAP's Quality and Clinical Data Registry Committee. Dr. Bocsi is an Associate Professor of Pathology at the University of Colorado School of Medicine. And now it's my pleasure to turn the presentation over to Dr. Saad. Next slide, please.
Well, thank you, Ms. Wright, and good day to everyone. I'm happy to moderate our webinar today reviewing the proposed 2025 Medicare policy and payment changes for pathologists. The agenda is displayed on this slide right here. First of all, I will briefly review the policy, payment, and advocacy agenda of the CAP. Then I'll turn it over to my colleagues who will review in depth the proposed 2025 fee schedule changes, the pathology code impact and outlook for 2025, and the proposed 2025 quality payment program policy. And finally, at the end, we'll have a few minutes for questions. The proposed 2025 Medicare fee schedule and quality payment regulations were released on July the 10th. CAP members received a special advocacy update that evening with an initial analysis of this regulation. Today, we're going to go into more detail about the CAP's findings. The CAP will continue to engage with the Centers for Medicare and Medicaid Services, or CMS, over the next several weeks and comment on the proposed regulation. As is customary, the final regulation will come out in November, usually the first part of November, sometimes as late as Thanksgiving, and the final regulation will be implemented on January the 1st, 2025. So stopping Medicare cuts has been a major focus of our advocacy agenda. The CAP, AMA, and other physician specialties are pushing hard for Congress to now fix Medicare cuts for good. The latest dilemma that we're in is a result of the implementation of PAMA in 2015. If you recall, this was to replace the flawed sustainable growth rate that we had been under for over a decade. Well, over the past 6 years or so, payments to pathologists have decreased approximately 7%, while our practice costs continue to skyrocket. This downward trend continues in the proposed rule for 2025. So these cuts are on top of a lack of an inflationary update to the physician fee schedule. According to the American Medical Association, Medicare physician pay fell by 26% between 2001 and 2023 because physicians do not get a yearly inflationary update to their payments. And this trend has accelerated in 2024, given the inflationary cycle that we're in. So there's a growing gap between Medicare pay and inflation, as illustrated on this graph here from 2020 to 2025. So in 2025, we expect an additional forecasted cut of about 2.4% to our pathology payments. This is compared to an overall cut across the board of 2.8% to the 2025 conversion factor. So we're doing slightly better than the 2.8%, and Dr. McLawhon will go over that in a little bit. It's expected that inflation will continue upwards. Maybe it's moderating a little bit, but it will continue upwards into 2025. This trend is unsustainable. For those of you that are in practice, you know how supplies and reagents have gone up over the past several years. Our shipping costs have gone up 10 to 20%. Our salaries and benefits we continue to have to increase salaries and benefits, usually by 3 to 5% over the last couple of years, in our practice by 7 to 8%. The costs of instruments have gone up. The costs of service agreements and preventative maintenances have gone up by about 50% over the past few years. This trend is unsustainable. Congress must stabilize Medicare payments with an annual physician fee schedule inflationary adjustment. We will continue to tell Congress that short-term fixes are still required. However, we must also focus on a long-term fix. This was a featured ask of Congress during our Hill Day meetings of April of 2024. A long-term fix is not going to happen this year. It's unlikely to happen this year because of the cost, and we're in an election cycle right now. So we need a short-term fix while we continue to push for the long-term fix. So our asks of Congress to fix Medicare at PLS focused around about 3 bills. So the first bill was the Supporting the Strengthening of Medicare for Patients and Providers Act. This legislation would apply an inflationary update to Medicare's physician fee schedule. This would be the first step in providing crucial financial stability until additional bipartisan payment reforms can be enacted. This would tie payments to the Medicare Economic Index, which is a measure of inflation in Medicare practice costs. In 2024, this is anticipated to be around 4.6%. So we need to fix this. The second ask would be to support the Provider Stability Reimbursement Act, or HR 6371. This would increase the budget neutrality threshold from 20 million to 53 million. We recognize that this is a drop in the bucket compared to overall payments on the Medicare Physician Fee Schedule, but this is a step in the right direction. It would further provide a look-back period to reconcile overestimates and underestimates of pricing adjustments for individual services. Currently, if Medicare overestimates what they're going to pay and they say, for example, $500 million, that money is gone. It doesn't come back into the payments. It's gone. And so this would provide a look-back period for reconciliation of overpayments. It would require timely updates to the direct costs used to calculate the practice expense RVUs, and it would require the Secretary to limit positive or negative increases in the conversion factor to no greater than 2.5% each year, further preventing rapid swings or significant swings in payments, which can be very disruptive. Our third ask of Congress during the Hill Day visits, and we'll continue to press for these, by the way, for the remainder of the year and into next year if we have to. Our third ask was for Medicare to fix the clinical laboratory fee schedule. This is by supporting the Saving Access to Laboratory Services Act, or SALSA. Senate 4449. This would fix the flawed methodology that was enacted as a result of the passage of PAMA in 2014, which mandated market price calculations be used to set Medicare clinical laboratory fee schedules. Congress has temporarily delayed these cuts for several years, but new cuts of up to 15% are scheduled to go into effect on January 1 of 2025. These cuts would apply to over 800 tests if this isn't fixed. So with that, I would now like to turn the presentation over to Dr. McLawhon.
Thank you, Dr. Saad. So let's just go through the overall proposed payment changes for 2025. Dr. Saad mentioned about the conversion factor change. So for the 2025 fee schedule, the payment formula is decreased by 2.8% to that of the 2024 fee schedule. That's overall for all physicians. The decrease in the conversion factor is primarily due to two items. One is the expiration of the congressional relief of 1.25% from the 2023 Consolidation Appropriations Act, and then the supplemental relief that we lobbied for and with other medical organizations and got in March of 2024 of 1.68%. As a result of the changes, the CAP estimates that for pathology, it's going to be 2.44% overall impact to pathology Medicare payments, and 2.45% to the independent laboratory Medicare payments. So better than overall for the House of Medicine. So we'll get into what's driving that in a minute. Suggest that if you haven't already looked at it, please review the proposed 2025 Medicare fee schedule impact table that's on CAP's website. So that one thing to bear in mind is the decrease in the conversion factor as a result of a reduction in the temporary update of the conversion factor under current law. But also there's another factor involved here, which is a negative budget neutrality adjustment stemming from the adoption of the evaluation and management add-on code G2211. So that's a big driver here. Could I have the next slide, please? So for 2025, there's a continued pricing update. This will be the fourth and last transition year of non-physician clinical labor staff costs and inflationary updates. So past 4 years, CAP has successfully advocated to CMS to increase cost estimates for pathology's most commonly utilized non-physician clinical laboratory staff, clinical labor staff, mainly the histotechnologists and cytotechnologists. CMS agreed to implement all of CAP's recommendations, and those changes are a direct result of CAP advocacy with CMS. So those revised labor rates were applied within the CMS practice expense methodology. The updated increase to the technical component global payments for many pathology services paid on the fee schedule. And then this resulted in approximately a $12 million adjustment each year to pathology and independent laboratories. These increases offset the reductions from the budget neutrality adjustments that decrease the conversion factor. So the reason we're getting the 2.44 reduction compared to the 2.8 related to the conversion factor is, in fact, because of these clinical labor pricing updates. The updates are budget neutral within CMS practice expense relative to value units, while the update will positively impact many services with clinical labor, it will negatively impact those that are relatively more supply and equipment intensive. Next slide, please. So, success on the advocacy front, the couple of new CPT codes for calendar year 25, Category 1 codes. The May CPT editorial panel for CAR T cells, chimeric antigen T cell receptor services. And they added a new subsection to the CPT manual with reporting guidelines. So there are 4 codes there that are now Category 1, and they will be released in January for use in January, which will be replacing the existing Category 3 codes, the temporary emergency technology services and procedures that were created in 2018. This is for the acquisition and administering of CAR T cell therapy for certain types of cancer. Next slide, please. These are the 4 new codes. Again, one for harvesting, one for cryopreservation and storage, one for administration, and the receipt and preparation for administration. So these were taken through the RUC. The RUC recommended values were accepted by the RUC, or the CAP recommended, and the other special societies were accepted by the RUC. And CMS has also accepted those values that went through the RUC. Next slide, please. Therapeutic apheresis advocacy. These would be the 36514, 36516, and 36522. They were identified as potentially misvalued for practice expense only. We brought this to the AMA RUC meeting. It was a multi-specialty coalition looking at this. Basically, the desire was to change from the clinical labor staff type from a RN, LPN blend to an oncology nurse. And since there's nothing that would within the CMS to allow for the concept of an apheresis nurse, we used the oncology nurse as the proxy. These recommendations were forwarded to CMS, accepted, and are proposed for calendar year 25. If it comes out in the final rule, this advocacy increase will increase the reimbursement for these apheresis services to mitigate any cuts in the non-facility setting. Next slide. Just going through some of our top services, like the 88305, 307, special stains, immunohistochemistry stains. You can see the changes for the professional component, the -26 modifier. It's between 2% and 3% change across those. If you go down to the technical component and look at those, you can see, again, 3 or 4% reduction. However, the IHC stains did go up by 6 to 7%. And you can see that effect when you look at the combined of the -26 and TC services. Again, 3 to 4% reductions for 8305 sevens and the special stain groups, but a positive increase on the global for IHC. Next slide. The largest changes are illustrated here on this slide. The 88355, both TC and global went up significantly. The IHCs I've already mentioned. 88104 went up for non-gynae smears, cytopathology. And then you can see the ones that went down. immunofluorescence for antibody stain, flow cytometry, in situ hybridization went down by about 7%. The morphometric in situ hybridization, quantitative, semi-quantitative, were a little bit more than that. The 8374 decrease was not due to any change in physician work or practice expense inputs. Those changes are the result of the nature of CMS's practice expense methodology, and we're going to review these decreases carefully and follow up with CMS on those as well. Next slide. Just let me mention a little bit about the physician practice information survey, the PPI. This ends at the end of August. Many of you should have received requests for this, filling out this a very important survey. This work hasn't been done since the early 2000s, and it really makes a big impact. And it's one time that you can really help advocacy by filling out the practice expense survey. So this is an AMA-led focus on indirect practice expense cost data. These data are key to future updates in the Medicare pay formula to reimburse pathologists. There's a considerable interplay between the indirect practice expense and what goes in, what we finally get paid. So these updates are going to be critical and get accurate information. So be on the lookout for any email that comes through with the subject line that says American Medical Association request your input on physician practice expense and patient care hours. The information and reminders about the PPI survey to financial experts at practice will come from the email address listed there, as well as invitations and reminders about the physician hours surveys to physicians will come from this other email listed on the slide, physician hours survey at mathematica-mpr.com. So this is a joint effort between Mathematica and AMA. Next slide. For the independent laboratory, we have a separate survey, the Clinician Practice Information Survey, CPI. It technically ends on August 2nd. They're updating practice expense per hour data to calculate payment rates for physicians paid on the physician fee scale with the focus on indirect practice expense cost data in the independent laboratory settings. Again, these data are key to future updates in the Medicare pay formula. And again, be on the lookout for this email subject line. The College of American Pathologists requests your input to update Medicare clinician payment. So the one for the physician survey, the practice survey will come with the AMA, and the one for the clinician practice information survey will come with College of American Pathologists request your input on Medicare clinician payment. Again, invitations and reminders of the survey will come from CPI survey at mathematica-mpr.com. Okay. And with that, I will now turn this over to Dr. Bocsi, who will review the finalized changes to the quality payment program and the MIPS requirements for 2024.
Thank you, Dr. McLawhon. The slides, can we actually go back one slide? Okay, and then now come forward one, please. Okay, as a refresher, if you've been on these calls before, you know that there's two pathways offered under the quality payment program, MIPS and APMs. So MIPS being the pathway for clinicians under the QPP who aren't qualifying as a participant in an advanced alternative payment model. And as we described previously, CMS has declared that they want all beneficiaries in an accountable care relationship, which would mean that physicians would be in value-based payment arrangements by 2030. In fact, we know that CMS would ideally like traditional MIPS to go away in favor of these advanced alternative payment models, but it's not realistic right now. And so in the interim, CMS introduced a transitional pathway between MIPS and APMs called the MIPS value pathways, or MVPs, that you see here. And we'll talk about those a little bit more in a moment. Next slide, please. So what you see here is some historical perspective. And CMS tends to increase the requirements on participation. And ways of doing that include increasing the minimum number of points you need to achieve a neutral payment adjustment, as well as the percentage of all cases that need to be reported to CMS. So for 2025, CMS is proposing to maintain the performance threshold and data completeness at 2024 levels. And so what you see here is CMS is proposing to keep the 75% data completeness threshold. And not only that, they've indicated that it would stay at that point through calendar year 2028. All things considered, higher performance threshold, data completeness thresholds increase the burdens of participation. And last year, CMS proposed to raise the performance threshold to 82 points, which would have resulted in more individuals getting a negative payment adjustment. So at that time, it was a key advocacy win that they didn't increase it further. So on balance, keeping it steady isn't that bad. Next slide, please. So in terms of how scoring happens, as non-patient facing physicians, as you've probably heard before, pathologists are scored on quality and improvement activities primarily. Now, quality measures, therefore, are proportionally the largest percentage, particularly for large groups, which CMS defines as groups with more than 15 pathologists. And so for those large groups, the quality score from the quality measures constitute 85% of the total score. Small practices are reweighed, so the quality and improvement activities are each 50% of the score. Because we're a non-patient facing specialty, we automatically qualify for reweighing of the promoting interoperability category. And as far as the cost category goes, pathologists are almost never scored on cost, because to be attributed to a cost measure, you have to bill certain trigger codes, and pathologists seldom bill any of those codes. So what you see is that below a score of 75, you'll qualify for a negative payment adjustment. 75 points exactly is neutral, and above 75 points is the potential positive adjustment. That 75 points is a high bar, especially for larger practices, particularly if you're relying on top-down measures. Now, there's a proposal regarding top-down measures that I'll come to in a moment, but it is important to be aware of the scoring criteria and the measures that are available to you if you're participating in the MIPS program. Next slide, please. Another thing that won't change this year is the pathology quality measures set, so no additions or subtractions there. There's 7 pathology measures available for reporting, and these are available to any MIPS eligible pathology practice. It's good that they haven't proposed removing any measures, which is a threat that we've faced in the past. Next slide, please. Now, a pleasant proposal for 2025 is a proposal to change how top-down measures are scored. And if adopted, then the CAP's QPP measures could be worth up to 10 points again. So previously, top-down measures received a cap. So if you see in the table on the left how the scoring worked, even if you got 100% performance rate, you were capped at 7 points. The proposal for 2025 is what you see on the right. And so that table on the right in the left-hand column under performance rate, it shows that there is the possibility for some grades of performance. Now, the performance still has to be very good, but within those categories, you would receive, up to 10 points if you are perfect. So we see this as potentially beneficial because relative to where we were with the top-down measures being capped, it does allow us to get back up to a full 10 points. Next slide, please. Now, CMS is also proposing something that we do not favor, and that is a reduction in the available options for improvement activities. And in particular, they're proposing to remove several improvement activities that are commonly performed by pathologists. The rationale that they've stated is that they're no longer relevant. We disagree with that and will be advocating in that manner. Remember, your improvement activities are 15% of the pathologist score for large practices or 50% for small practices. So improvement activities after quality are our most important category. And with reduced options there, that may be something of a disadvantage that we're going to work against. Next slide, please. I said we'd come back to the MIPS value pathways. So they introduced this new arm of the QPP, and it's intended to serve as a transition between MIPS and advanced APM. So they introduced this in 2023, these MVPs, MIPS value pathways. And in theory, they're a more coherent set of quality measures, cost measures, improvement activities that have some relationship with one another and are focused on a single clinical topic. Now, in many of the elements of MVPs, such as the promoting interoperability category, are something that pathologists don't currently do, and the population health measures don't apply to pathologists. So it's been unclear how pathologists would be able to participate in MVPs. And in fact, we're engaging vigorously with CMS to figure this out for pathologists. Next slide, please. So here you see a list of MVPs, and in the green box are new ones that are proposed for 2025. So far, pathologists aren't in any MVPs. However, a new thing in this proposal is that they've proposed to include two measures that pathologists report in an MVP, the dermatological care MVP. That doesn't suck us into the MVP, but that is something that we haven't seen before. And as I mentioned, we're acutely attuned to this issue and investigating how we might eventually participate in MVPs. Next slide, please. As I mentioned, CMS would like, ideally, to have 100% of traditional Medicare beneficiaries and accountable care relationships by 2030. And they're looking at how to shift physicians into those types of arrangements. Now, to be a qualifying participant as an eligible clinician, there's specific criteria that have to be satisfied. So CMS assesses the level of participation based on payment amounts or patient counts using sort of threshold percentages. And then they calculate the ratio of attributed beneficiaries to attribution eligible beneficiaries. The proposed rule includes changes to the criteria used to identify attribution eligible beneficiaries for the purposes of these determinations. And it also reflects changes made by Congress, including to continue the APM incentive payment amount for performance year 2025. Next slide, please. Now, CAP coordinates with the AMA and other specialty societies when it comes to protecting independent practices and the right to practice medicine as a pathologist. One of the things that we continue to advocate is for maintaining traditional MIPS as well as reducing the burdens associated with MIPS reporting. A key initiative is understanding how pathologists will be able to participate in MVPs, but then also beyond that, how will pathologists in independent practices be able to participate in ACOs and APMs without being forced to consolidate or merge with other practices. So we're trying to figure out both of those things, understanding MVPs and how pathologists can meaningfully participate in APMs and ACOs. And we continue to engage with CMS, expressing the concerns of pathologists and learning how to prepare pathologists for the future in these programs. Next slide, please. Now, a real advantage that pathologists have is we have the Pathologist Quality Registry. And this is something that can really help members out who are participating in MIPS. The Pathology Registry team can give you practice-specific advice, help you to select the highest scoring measures for your situation. They have different choices for how you submit your quality measures. There's manual data entry, Excel file upload, automated data entry, billing, or LIS integration. And just like helping to select with the quality measures, the registry staff can help with selection of improvement activities and understanding what those improvement activities are and what ones might suit your practice well. Remember, even if you're facility-based, you still need to submit improvement activities. And the contact information is there. And if after listening to this, you're a little foggy on actually how you are participating in MIPS, there's the link to the website. You input your NPI and it tells you what your eligibility is under the quality payment program. Next slide, please. I'm going to turn the presentation over to Dr. Saad for questions now. Thank you.
Great. Thank you, Dr. Bocsi. Thank you, Dr. McLawhon. Please type your questions into the chat feature and we'll answer them. And I'm now going to ask Ms. Wright to read the first question.
Thank you, Dr. Saad. The first question I'll direct to Dr. Saad, and it is, could you tell us some more about the Independent Laboratory Clinical Practice Information Survey?
Yes, thank you for that question, Ms. Wright. It's a little bit confusing. There are two surveys out there. Let me try to explain it. Medicare hasn't updated the indirect practice expenses for almost 20 years, as Dr. McLawhon indicated earlier. And so this is an attempt to get data, specific data on specialty data on the practice costs and the hours physicians spend providing direct patient care. So the first survey that's out there is the Physician Practice Information Survey, or the PPI survey. This is intended to collect data on anatomic pathology services from pathologists that bill under the Medicare Specialty Code 22. This would include like physicians who are PC billers only, hospital-based practices. It's important that we fill out that survey. The Independent Laboratory Clinician Practice Information Survey is one that was actually developed with the help of CAP, because we recognize that the practice expenses, the overhead costs of independent laboratories are very different from one pathology practice to another. For example, the PC billers only don't have the same overhead costs that an independent lab will have. And so this is a very important survey to fill out, because it will capture more accurately what the practice costs of an independent laboratory are. And so, as mentioned by Dr. McLawhon, the effort is led by Mathematica and the AMA with CAP participation, particularly when it came to developing the independent laboratory practice survey, because we recognize our costs for independent laboratories so much different. So please be looking for the survey in your inbox, fill it out. The survey closes in August if you start it before August 1. So if you start it today or tomorrow, you will have at least 2 or 3 weeks to complete it. So please get it started. The data collected is very important. It has a great effect on it, particularly the technical component reimbursement for our CPT codes. It can be up to 40% of what we get reimbursed on the TC side. So it's very important that we get accurate data, fill it out, and help the AMA to give this information to Medicare so that we can get paid appropriately.
Thank you, Dr. Saad. The next question will be directed to Dr. McLawhon. And it looks like it stems from some observations looking at the impact tables that we displayed. And the question is asking that it seems like the money is just being taken out of the professional component and moved over to the technical component. At least that's the observation for IHCs.
Yes, so it may seem like money is just being shifted around, but the PC and the TC components are uniquely and distinctly calculated by CMS. That decrease in the IHC PC is, as we said earlier, and across all our services right now, that's due to the decrease in the conversion factor and the budget neutrality impacts. The increase in TC is directly due to some of the CAP's advocacy with the cost components that CMS uses in their expense methodology. This is particularly the clinical labor costs that we've talked about, and the cost of supplies, equipment used for each IHC service. But I think really what you're seeing is how they've weighted in this particular cycle, the TC, for the TC, the clinical labor expense. Again, PC and TC are separately calculated by CMS.
Thank you, Dr. McLawhon. The next question will be directed towards Dr. Bocsi. The question is, a couple of years ago, the CMS was proposing to get rid of the current MIPS program. Is that still going to happen?
Well, I can't tell from the question whether you sound disappointed or pleased by that, but yes, we think so, but not imminently. CMS is certainly moving forward with the implementation of MVPs, and part of the motivation for that is that traditional MIPS would be sunset when there's sufficient coverage with MVPs. They haven't proposed an official end date yet. What we continue to do, the CAP and the Quality and Clinical Data Registry Affairs Committee, is to investigate how pathologists will participate in MVPs so that we're prepared well before traditional MIPS goes away. And on the same front, we also continue to advocate that traditional MIPS doesn't go away for a long, long time. The other thing that may be of interest is that we coordinate and engage with the American Medical Association on questions of the quality payment program. And recently they've been putting together a proposal to replace MIPS. So, that's certainly not going to happen tomorrow or who knows when, but we're working to ensure that any proposals to update, refine, or replace MIPS ensure that pathology is fairly valued in any future payment schemes.
Thank you very much. The next question is for Dr. McLawhon, and this is a follow-up to your discussion on the new CAR-T therapy codes. The question is, can we use these new CAR-T therapy service codes now?
The answer is no, not now. The codes are placeholders. They will be published in the CPT book probably in the fall, late summer, early fall timeframe, and these codes will not go into effect until January 1st of 2025, so they can't be used until 2025. So for the remainder of 2024, calendar year 2024, you still have to use the CPT Category 3 Temporary Code 0537T through 0540T.
Thank you, Dr. McLawhon. The next question is back to Dr. Bocsi. The question is, I'm in a small practice and improvement activities are 50% of my MIPS score. Since CMS is getting rid of this activities I've been doing, how do I know what activities to do instead?
Okay, so I think you looked at the list, you saw something you do and report there. So I guess in that regard, that's their proposal. Of course, we will try to discourage them as best we can. But assuming that it goes through, the first thing I would say is that if you participate in the pathologist quality registry, reach out to the registry staff because they'll be all over it. They'll help you identify, suitable alternative activities to substitute. In any case, if you're not using the pathologist quality registry, there is a list of improvement activities for relevant pathologists on the CAP's website under the quality payment program for pathologists section. So I'd recommend reviewing that list and seeing what might suit you. That list in particular includes activities that other pathology practices have successfully submitted to CMS in the past. In addition, the CAP Quality and Clinical Data Registries Affairs Committee has been working to develop new improvement activities that would be a good fit for pathologists. And in fact, we submitted to CMS two for consideration for inclusion in the 2025 rule. Now, neither were accepted, so we're going to get some feedback from CMS to find out if we can improve our submissions for next year. But we keep an eye on it and we recognize that this is a concern, particularly for smaller practices.
Thank you very much. And then I have a question for Dr. McLawhon, stemming from the discussion on the across-the-board cuts. I'm asking if you could please explain how the 2.8% reduction in the conversion factor was derived.
Okay, so the cut in the conversion factor is largely the result of the expiration of congressional relief. That would be the 1.25% relief we saw with the 2023 Consolidated Appropriations Act, plus the 1.68% relief from supplemental relief package that was passed in March of 2024. The expiration of this relief at the end of 2024 will actually decrease the conversion factor by 2.93%. The reason it's only 2.8% is there's some positive budget neutrality adjustments from policies that the agency announced in the proposed rule, which would generate some program savings. Savings stem from some small adjustments in work RVUs from non-pathology services, as well as a proposal to require the use of a transfer of care modifier when physician plans to furnish only a portion of the 90-day global package. So that 90-day global package estimate is estimated to save about $143.5 million to CMS and allowed charges for calendar year 2025. That will help offset that 2.93 decrease from expiration of congressional relief, and that's how we got to the 2.8% level. And I just would say, I think, we've been dealing with these congressional relief packages the last couple years related to the E&M rollout and the G2211 add-on code rollout. While we will continue to advocate for that, I think the Congress has made it clear that they're not really interested in continuing to do a lot of these patches to deal with this. So I think we need to be prepared for that going forward. The things that Dr. Saad spoke about earlier on, the larger initiatives going on through Congress, some of these other bills are going to help try to address these issues. But that's how we got to the 2.8%. So thanks.
Thanks, Dr. McLawhon. We have another question that just came in, Dr. Bocsi, and it says, if you can choose, which is more advantageous, participating in MIPS or APMs?
Well, that's why we said on that slide, it's a strategic decision. Unfortunately, it's hard to say across the board without kind of looking at one's very specific practice scenario. I think some people would reasonably feel like whichever is less burdensome in order to participate may be appealing, but there are good reasons where you could go either way depending upon your circumstances. So I guess I can't give a general answer based on, without very specific details, but as much as we're able to, we try and provide that type of guidance. And again, the registry staff is another group that's very knowledgeable about the ins and outs and can help a practice make those decisions.
Thank you. And that was our final question. So I'll now turn it back over to Dr. Saad to close us out.
Thanks, Ms. Wright. I would just like to add, many of us can't choose. We don't have a choice right now. We can't participate in APMs. So we're very grateful to have the MIPS option, and that's why we want it to be extended for as long as possible while we figure out the MVPs and then the APMs. So many of us don't have a choice. Well, thank you all. We're now getting close to the end of the program. If I could have the next slide, please. Please stay informed. Follow CAP on our X handle, which is at CAP DC Advocacy. We're also on Facebook and on LinkedIn. Please, if you haven't recently visited the CAP advocacy page, go there and visit. There's a lot of information. It's updated and much improved, including information about LDTs. Also, be sure and look for the Advocacy Update newsletter that hits your mailbox every Tuesday afternoon. And there's a lot of information there. So please read it. Be sure and join PathNet, which is CAP's grassroots advocacy network. If you get an action alert, please respond. If you have the opportunity to do a lab tour with one of your Congress people, please do that. Participate in town halls, visit your legislators in person if you can, and probably in the fall, maybe in October or so, we'll be having another virtual fly-in, so be looking for that information. As was discussed earlier, please fill out the physician practice information survey and the independent laboratory clinician practice information survey. These will be closing soon, but please get them started, and you will have 2 or 3 weeks probably to complete them. So with that, that's all the time we have for today. If you think of any additional questions, please email them to advocacyupdate@cap.org. I want to thank you for participating and thank our presenters, Dr. Bocsi, Dr. McLawhon, Ms. Wright, and certainly all the CAP staff in DC. So thank you again for joining us, and have a good day.